Good morning. I'm Gordon Smith, the state's director of Opioid Response in Governor Mills' office. My pleasure to welcome you to our monthly Opioid Response webinar. We will continue to have one the first Friday of every month from 11:30 to 12:30 until we culminate with the governor's eighth and final, in her case, final summit on July 16th in Bangor. Today, we've got a program on collaborative partnerships, supporting individuals with co-occurring disorder, enhancing care through collaboration and partnerships through our certified community behavioral health clinics. And we're very happy to have with us Brian Moynihan from CHCS, Community Health Counseling Services, primarily in Bangor. They have other offices around the state. And Brian is the manager of specialized community services at CHCS. We were going to have Leslie Lennig with us as well, but she's unable to make it. Brian will be doing the presentation and answering your questions. I want to make just a few announcements if you have any questions, please put them in the question and answer box and not in the chat. Sometimes we disable the chat. In my screen, you have to go over to the little circle with three dots in order to, I think, get into the question and answer. No, I take it back. There's right on the bottom of my screen, there's a question and answer thing. That's where we'd like to have you put your questions. Some of them we'll answer as we go along. Some of them we'll answer at the end. If we don't have time to answer all the questions, we put them on the website. I remind you that all of these programs are offered free of charge. They're also all recorded so that they are available on demand for anybody that would like to watch them in the future. We have three really exciting programs coming up in January, February, and March. We've got a real international flavor the first 2 months. In January, it won't be the first January because that would be the second, the day after New Year. So we're going to do it January 9th. And we're going to have another discussion with our former colleague, Roland Robinson, who is still on his Andrew Weil Fellowship and doing drug policy, study of drug policy in Latin America now. He's in Brazil, and I'll be talking to him about what he's learned down there. In February, we've got a program featuring prevention by our friends in Iceland from Planet Youth, who will offer to us information on the Icelandic model. That model got a lot of attention 6 or 7 years ago when they had a dramatic decline in youth, adolescent alcohol use as a result of this model. And it's been adopted in a number of states. And we have people in Iceland now who are working with them, and they're going to present on that model in February. And then in March, we have a group from Los Angeles, Song for Charlie. It's a nonprofit organization that's does prevention work. Family lost Charlie to one single fake pill in his last year of college. And they've formed a foundation, and will also be presenting at the summit on July 16th. So they'll be presenting. And right now, I've asked them to focus on their work with the faith-based communities. And so that's the area that they'll be talking about in March is how can our faith-based communities in Maine help us with the substance use problems in Maine. So that's all I have in the way of announcements. Again, we continue to see a decline in our fatal overdoses of about 18.7% as of last Sunday. So we're hoping to continue this good work in December and close the year with what we hope, frankly, will be just under 400 deaths. It sounds awful, more than a death a day rather. On the other hand, it used to be almost twice that. So we are making progress, and it's due to all the good work that all of you do. So with that, I'm going to turn it over to Brian. He's got great information about how this work is going with I think we have 5 CCBHCs now in Maine, something like that. And Brian's going to talk about collaborative relationships and partnerships. And Brian, we really appreciate you being with us this morning.
Thank you, Gordon. Yeah, and I will be sharing the screen in a bit to get my slides going. But yeah, I'm Brian Moynihan with Community Health and Counseling Services. For those that don't know, we're a large mental health and substance use organization housed out of Bangor, but we have a statewide reach. And we were asked to kind of present, in part, talking about the CCBHC model, which is a new model of care to the state of Maine for providing Maine care funded behavioral health services. And to include mental health and substance use services. And in kind of thinking about how to kind of frame this presentation, kind of my thinking, the CCBHC model kind of is a logical kind of next step to work that we've already been doing over a number of years. And so I wanted to kind of talk a bit about the kind of evolution and how we've gotten to where we are right now as an organization, and then the role that the CCBHC model will play moving forward and sort of formalizing some of the improvements that have already been made and kind of what we see in the future for our CCBHC and the opportunities that CCBHCs present in general for improving care to folks with co-occurring substance use disorders. And as Gordon said, feel free to throw questions into the box. If there's anything that comes up that would be helpful, and I do well with questions, I'm going to leave time at the end too for any questions or discussion as well. So I appreciate you guys hosting us. And yeah, Leslie regrets that she wasn't able to join us here. She's our clinical manager and has been overseeing the implementation of our CCBHC. So I will try to fill her shoes as best I can as well. I'm going to, without further ado, share my screen. And looks like the technology gods are working with me today. If you're not seeing my slideshow, please let me know, but I'm going to assume that you are. So I want to start just with a little background about community health and counseling services to kind of frame things up. And it's interesting you mentioned that Gordon, that one of the upcoming webinars is going to be looking at faith-based organizations and how they can be a part of the solution. A little history of community health and counseling services. The organization that eventually became CHCS has been around since 1883 and actually was founded by a group of women from various faith-based and religious organizations in the Bangor area, looking to really consolidate the charitable work that they were doing among multiple organizations, pulling together and better enhancing how they could provide charitable work to the Bangor area. And over the 100 some odd years since then, close to 150, the organizations evolved into what CHCS is now, which is a large multi-service organization. We provide home health and hospice services, as well as a whole range of behavioral health services statewide. Our main office is here in Bangor, but we have sites in Manchester, Dover, Foxcroft, Lincoln, Machias, Holton, Presque Isle. So statewide reach and some variation office to office as far as what programs we might provide in each area. But it's kind of cool. I was kind of pleased to hear that the faith-based connection is going to be there in the upcoming webinars, because that really goes to the roots of how CHCS first came to be as well. So talk a bit about kind of the evolution of substance use services within CHCS and how that kind of fits into the big picture here. So we've been, for the majority of our history, the behavioral health side of our organization has been very focused on the mental health side. We have a lot of depth of experience in the whole range of behavioral health services, working with folks with mental health conditions, everything from child and family-based services. We've always had a robust treatment foster care program, outpatient services for youth and adolescents, to lots of specialized programs working with adults with severe and persistent mental illness. So we've got a really, robust history of providing behavioral health services, much less so historically around substance use and co-occurring disorders. As we all know, that you really can't separate the two, but historically, our systems have largely been very siloed. You have this sort of the mental health avenue, substance use avenue, and in many cases, it's been separate agencies providing those services, or even within one agency, kind of separate programs, and integration has not always been the standard there. And thankfully, that's been changing over time, and I think that's really leading to a lot of enhancements where the CCBHC comes in as well. But we have historically had some components of SUD and co-occurring disorder treatment within the agency. Thinking going back to like the 90s, the ACT model was something we first implemented here, and that again is a program that has substance use treatment incorporated into the program with a substance use counselor because of that knowledge that there's very often co-occurring substance use and mental health conditions, and you really need to be able to treat them both simultaneously to be effective. We had I don't know if folks have been around in our system on the mental health side for long enough, but back in the early 2000s, there was an intensive community integration program, and we for a while had an intensive community integration team that was focused on folks with co-occurring disorders. So we did have a substance use counselor that was overseeing that team and provided community-based case management services to folks with a focus on co-occurring disorders. We've had a limited degree of outpatient MAT treatment through our outpatient mental health and psychiatric clinic, providing Suboxone, but again, it's been fairly limited in scale. Things in the past 5 years or so, there's been quite a bit of growth. A big part of that has been the Options Initiative statewide. CHCS is the options provider for Penobscot and Piscataquis counties, and the implementation of that program has really been a huge boon as far as helping propel us towards providing much more robust integrated care and stitching together the various resources that we have to better meet the needs of the folks we work with. I'll be talking quite a bit more about options down the road, but also we have a couple other programs that have developed that are SUD focused. We contract with the Penobscot County to provide their in-house SUD services and assessment for inmates in the Penobscot County Jail over the past few years, and also have a statewide collaboration with the Office of Child and Family Services, providing substance use consultation for families that are involved in the CPS system, assessing parents and children when there's substance use as a component of their involvement. So we have a lot of these programs that are addressing substance use, but again, we still are in that kind of growth process, looking for how to kind of expand, how to build upon that. And the CCBHC provides a great vehicle for that. So as I said, one of the kind of impetuses for change has been for this webinar series for the options program. A lot of what we're doing is the opioid crisis. As we know, it's been a dramatic crisis that we've faced in our state and nationwide with opioid deaths, and the state has been putting a lot of resources and work into how to address that. And as Gordon mentioned, the numbers for overdose fatalities have been going down, which I think is in large part due to the work that the state and organizations have been doing to try to creatively address that, how to address overdose risk, kind of connect people with services when they need it. So the option program obviously is a big part of that. And really the options program, for those that I imagine most of us are familiar with it, but it's really aiming to reduce barriers to access to substance use care, to promote awareness, reduce stigma, and really meet individuals where they're at, try to figure out, how to connect with folks that are at the highest risk of overdose, and figure out what their needs are, help them connect to supports when they're ready for that. That includes folks that are unhoused, that is recently, discharging from residential treatment, from incarceration. And we've really, with the options program in the Penobscot County area, because this is a service hub for the northern part of the state, and because also we have a large homeless population, we're looking at how to really meet the folks, connect with folks that are at the highest risk. And we're finding in Bangor, there's a huge overlap between the unhoused population and folks that are actively using opiates. And so really a lot of the work that our options team in Bangor has done is try to how to best build those relationships and make connections with that part of our community. Also, in a similar time frame, is where the kind of CCBHC comes along. Now, the CCBHC, it's a nationally known model, certified community behavioral health clinics. It's a model for providing really well-integrated behavioral health care to individuals in their community. The state has implemented this model as a main care model this past year. Prior to that, though, we had the portion, CHCS and several other organizations had SAMHSA demonstration grants, which allowed us to start to, make those moves towards shifting to a CCBHC model prior to that. So we've had the benefit of, developing the CCBHC model over a number of years. And part of what the CCBHC does is really looking at integrated care rather than having siloed behavioral health and SUD services or siloed categories of service. Piecemeal, it's really looking at the whole person, and when somebody comes to a clinic, it's really assessing what their overall needs are, and then whatever those are, trying to provide those services in a wraparound fashion. And part of that is looking at expanding what services are provided in-house, but also it's leveraging community partners and other organizations to help meet the overall needs of an individual in a coordinated way. One of the cool things with our demonstration grant, it allowed for, as they're called DCOs, designated collaborating organizations. So we really, as part of our partnership, realizing that no one agency can meet all the needs of all the folks that we encounter. So it's having to figure out where are the resources in the community and formalizing those relationships. So, again, we're a behavioral health HCD program. We're not a primary care organization, but individuals' medical and healthcare needs are essential to their overall behavioral health and wellness. So part of our partnership was partnering with PCHC, a local FQHC, to help formalize that connection. Partnering with Wellspring, a local substance use specialized program, Penquist CAP, which is a multi-service community resource organization. So really looking at creating those formal relationships, recognizing that no one entity, no one organization can meet all needs. So I think that really kind of started us on that pathway to where we're going. So I did talk a bit about the DCOs already. I think one of the things you're really recognizing is that, again, with the options program and looking at the opioid crisis, that the folks that we are encountering largely have very complex needs. We have individuals that are, say, for example, that may be unhoused, living outdoors, have an active substance use problem, may have some co-occurring medical conditions, may have a lack of resources, may have legal entanglements that are complicating issues, just multi-layered challenges. And we're really needing to figure out how to best, provide comprehensive support to folks. And, the other complicating factor, a lot of folks that have, the more barriers somebody has, the harder it is for somebody to reach out and access care. I've worked in this field for, 30 odd years, and it's not always easy for me to figure out what the right door is for, accessing particular service. So if I were, homeless, unhoused, struggling with substance use and mental health conditions, I may be very much lost and try to, proactively reach out. So we want to figure out how to take the burden off the individual, stitch together services, and provide that in a comprehensive way. So one of the ways we did that early on was with options, recognizing that among our homeless and unhoused population that are struggling with substance use, a lot of medical needs and folks that really were struggling to access care, whether it's for primary care or substance use treatment. So we built on our partnership that we had through PCHC with the CCBHC demonstration grant to look at how do we best collaborate and meet the needs. And so what we started was a street medicine program collaborating with the PCHC Hope House Clinic. And that has gone from several years ago, once a day or once a week effort to right now we have street medicine outreach visits that happen 5 days a week throughout the city of Bangor. And it's a partnership between medical providers at PCHC and our options team and some of our homeless outreach staff to really get out there, locate people where they're at, and provide that on the ground. Everything from primary care, wound care, treating, bronchitis, to initiating somebody on substance use treatment, to getting folks into residential treatment and detox. And it has been kind of a gradual progression, but as the need has been, identifying the need has grown, been able to expand these services to what is really a very active part of what we're doing here. And it's, again, it's trying to, bring the services to the people that need them. and through that help move somebody into the more traditional service system when they're ready. One of the real benefits of this having already been in place is that I guess you also, I imagine, are familiar with the HIV cluster that's developed in the Bangor area and that the crisis we're dealing with there, because this partnership was already in place at the time that the cluster emerged. That allowed us to really flexibly respond and adapt and help step right in and try to address the needs of the folks that are impacted by the HIV outbreak as well. So it's really been a very kind of valuable opportunity we've had. But yeah, I've kind of listed, so PCHC has again been a big part of this partnership, but a number of organizations that we've developed close partnerships, both formally and informally through this process. Wellspring is a local substance use provider, and a lot of strong collaboration with them, both through outpatient SUD services, as well as their residential detox, residential treatment. Wabanaki Health and Wellness, they are, again, an organization based out of Bangor. They're running the needle exchange right now and have a range of social services as well. And they've been an important partner for us. Together Place Peer Recovery Center, where they have, groups, drop-in center. We actually have a recovery coach and peer support specialist that is a Together Place employee that partners with our options team to do joint outreach to provide that, that peer perspective in the work we do, which is invaluable. Whether it's, engaging with folks on the street that might not, me, old white guy that hasn't kind of necessarily had firsthand experience with addiction, somebody may not take what I have to say seriously, but somebody's been there, somebody that's, that has themselves overdosed, that has been out of jail, is able to approach somebody in a different perspective and help with that engagement. So that's been a huge benefit. Same with Bangor Area Recovery Network. It was a great organization in town that we link folks with frequently. The City of Bangor Public Health, St. Joseph's Healthcare, and that's just kind of a starting point. But there's a lot of organizations. We've really done a lot of work to build those relationships between organizations, between individuals working in those organizations, to then better serve the folks that we're trying to meet the needs of. That's where we're really looking at the link with the CCBHC. So, CCBHC model, it provides an opportunity to really look more flexibly at what the needs are of the community. And we want, what we're providing for services to really kind of meet those needs. So there's going to be some services that are just kind of core to what we want to provide. Any kind of CCBHC is going to have, traditional outpatient psychiatric care, case management, med management, care coordination, substance use counseling and assessment, recovery coaching. A lot of those core services are things that are just essential to have in-house. And we're going to be doing that. But we also want to really look at what are the needs in our community? What are, every community is going to have different priorities, different mix of services available, different needs, and what kind of similar like how the options program is played out. The options program and how we operate in Bangor is going to look very different from what options looks like. And it does look very different from what our options program looks like in Dover and Piscataquis County. And again, that's going to be very different from how options is operating down in Portland and Cumberland County, because the needs of those communities are different. And we want to be able to adapt and provide what the community needs. It's not cookie cutter. And so again, because that's allowed us the flexibility to look at what the needs here are in Bangor to meet the folks at highest risk of overdose. It's really collaborative, work with medical providers and street medicine. Up in Piscataquis County, it's going to be very different. I look at the CCBHC model in the same way. While we have that core of services, we really want to look at beyond that, what are the needs in the community and how do we best meet that? We don't want to recreate the wheel and provide services that really are unneeded or not in demand and neglect areas that are really missing out there. So we're really looking at leveraging partnerships where that's going to be most effective, and then providing the care in-house where that's going to be most effective. So things like, the partnerships that we've been able to develop over the years, looking at, Wellspring services. They have a robust detox program. They have a robust IOP right in town. So there may not be a demand in the town for having another substance use IOP. There's already a program that knows that inside and out And where we have that close relationship, we have somebody coming into our CCBHC. They may have multiple needs. One of those might be a substance use IOP. Hey, great. We already have that partnership, those relationships. If that's really what's going to meet somebody's needs best, part of our care coordination is helping link them seamlessly to another organization that may have that right service, versus they may be getting, recovery coaching and outpatient psychiatric care through our organization. And part of it is really just listening and hearing the input of the folks that we're really trying to serve, what their needs are, where they see the gaps, what are the challenges, what's getting in the way of them reaching recovery, them reaching the treatment they need. Because I think that's going to go a long way to really being able to build trust and provide effective care to the folks that are most at risk. Is really making sure that we're listening to their needs, to their input, and that we're using that input to sort of guide and shape the model of services and what we're providing. And so, like I said, CCBHCs are going to vary depending on location. CHCS's CCBHC is covering the Bangor office, our Dover Foxcroft office, our Lincoln office, and our Ellsworth office. So 3 counties, 4 different offices. And the service landscape in Bangor looks dramatically different from how it looks in Dover Foxcroft, for example. And so what we're really needing to do is, twofold. It's really, not, reinventing the wheel, providing something that's not, not needed, but also look at, what we've created in Bangor, and we have a, robust range of services, both external and internal. How do we then look at replicating that same type of support, that same type of comprehensive wraparound care in areas that don't have that right now? So thinking about opportunities under a CCBHC, someplace like Dover Foxcroft, Piscataquis County, very rural area. It's not a huge service hub like Bangor is. So there's really a lot of unmet needs. A lot of folks that may be up in that area have had to travel to Bangor to meet their needs that may not be readily accessible. Substance use counseling services on site, recovery coaching might be challenged to access. So we want to look at how do we then use the CCBHC model to really bring the services to the areas that need it. So being able to look at, hiring on recovery coaches and providing substance use counseling up in the Dover office, so somebody doesn't have to travel all the way to Bangor to get services, where they may have the opportunity to meet in person with somebody where previously they may only have, telehealth options available. And the other thing, though, we want to do in those rural areas is, again, replicate. We've had that success of strong partnerships with other organizations in the Bangor area to really meet the needs best, and that is something that's replicable up in rural areas too. For example, up in Piscataquis County, there is a recovery center in Sangerville, which is a great resource, much needed. And so partnering with that organization to really help link people with the recovery community, and then looking at where those gaps. So I think like Dover Foxcroft or Piscataquis County, transportation is a huge gap. So that's one of the areas where we have partnership with the recovery center. Then our role is figured out, okay, how do we then help problem solve and meet the needs of folks that want to access those resources, but transportation may be a barrier. So that's where the CCBHC's care coordination, case management may come in play, helping somebody figure out how to problem solve that so they can access the care that they need. Same with things like SUD care, MAT, really looking at how to help people bridge those gaps to the services they need. Doing things like reaching out and developing relationships with local medical providers and the local hospital. Because again, we're down in the Bangor area, we have lots of specialized substance use providers. Up in rural areas, there just isn't the population to support that. So we've partnered and reached out to, say, the hospital in Dover, where often they provide a lot of FCD services, or primary care offices that provide a lot of MAT and Suboxone, so that we can then help better coordinate and collaborate. If somebody's getting their Suboxone through a primary care clinic, we want to be able to then, closely integrate support that we can provide, whether it's case management, substance use counseling, mental health care, in a collaborative way with that primary care provider, so the individual is able to still get that comprehensive co-occurring disorder treatment without having to, go outside their home area to try to find that care. So I think there's a lot of exciting opportunities that this model offers, because there's that flexibility. It's not a fee-for-service model. It's not a siloed model. The intent is to just start with where the person is at, comprehensive assessment, determine what their needs are, and whatever those needs are, figure out how we're going to meet those in a wraparound model through our in-house supports and external. And similar, we're going to have similar processes in the other rural areas. Lincoln again is pretty limited resources, pretty limited services, so it's really going to be. I see sort of the CCBHC model almost be sort of a hub. There's a lot of, it's not a perfect analogy, but there's going to be a lot of services that we provide in-house, but also we're going to be kind of having those connections to those spokes of the wheel, all the community partners that are really going to help enhance and build upon the support we can provide to somebody. And just again, the flexibility of being able to provide responsive services in the moment. Excuse me. And just kind of give a couple examples of what this model kind of allows for it. And again, the one of the kind of important parts of a CCBHC is low barrier access to care, and the idea of being able to walk into the organization any day and have your needs triaged and figure out what those are on a rapid basis. We don't want people having to, when somebody has a need, they call up and say, yep, we can schedule you for an intake in a month and a half, or we'll put you on a wait list. That doesn't meet somebody's immediate needs. And especially with folks that are most vulnerable, you really want to be able to capitalize on when somebody is at that point in life where they're ready for change. And that's, again, part of the hallmarks of what the options program was designed for, is to meet people in the moment when they have that motivation for change and capitalize on that to help provide that support in that moment. And so the CCBHC aims at doing the same thing, the idea that somebody can walk into the clinic any day and be able to connect with somebody to assess what those needs are. To give an example, just recently in our office here in Bangor, we have our lobby is a pretty busy place. We have peer support that's housed in our lobby during all our business hours. We have a receptionist, so we're able to kind of really triage needs as somebody comes in. Had an individual that came into the office a couple weeks ago, was not currently a client of our organization, was not a clinic client, but walked in and had some significant needs. It was somebody that was unhoused, had some significant medical mobility issues, mental health conditions, and also really struggling with pretty significant alcohol use disorder, physiologically dependent on alcohol, and had reached a point where they needed help, and did the right thing. They just walked right into our lobby, and we were able to, again, having that immediate opportunity there's a peer support specialist housed in the lobby. Their sole role is to just engage with folks that walk in and provide that support. We're able to connect with that person, build that relationship, build a little bit of trust. And then when there was a recognition, okay, this person, there's a need for some immediate triage and assessment of needs, they were able to pull in some of our other staff to be able to kind of get into a little more depth, kind of help assess what the individual's needs were. And it was determined this person really, getting off the alcohol was their top priority, that they recognized that needed to happen. That was sort of key to making other changes in their life they needed. And because of the severity of their alcohol use disorder, they were really going to need inpatient setting for that to happen. So then the triage individual was able to reach out to our options team, and one of our options liaisons was able to come in, meet with the person, talk a little bit more, and really try to assess what their needs are, and then started making calls, trying to figure out, okay, where can we get this person's needs met? The stars were aligned in that case, and we were able to connect to St. Mary's, which is one of the places that's able to do inpatient treatment for alcohol use disorder. And we're able to determine that, yep, this person can actually, if we can get them down to St. Mary's in Lewiston, they would be able to be assessed and be able to be admitted for treatment of the alcohol use disorder detox, which again was that first necessary step towards this person then making other changes they needed in their life and addressing other treatment needs to get things on track. And we were able to just, again, with a little bit of coordination, a little bit of collaboration between multiple programs in-house and St. Mary's, make arrangements to actually just get our options folks and another one of our peer support staff were able to get this individual down to St. Mary's same day, get admitted for detox, which again was that first step towards a number of steps in this process for this person getting his life back to where he wanted it to be. And again, that sort of thing, I think, is what we want to see with the CCBHC model. It's going to be, everybody's needs are going to be different, and we need that flexibility and that robust network of supports and expertise to be able to assess those needs and be able to provide care in the right fashion and the right care at the right time to have success and recovery. And that's just one of many examples of ways that this model is going to allow for that. Think about other things like I mentioned the HIV crisis, and that's another area where this is an emerging need. A lot of overlap between the medical, substance use, social needs, and we're looking at, again, how do we then leverage the CCBHC model to provide that specialized care to individuals that we're encountering that may, among other things, be HIV positive. So again, that's looking at what can we do in-house. Do we want to, and what we have been doing is getting more training and get our case management and care management staff the expertise that they need around HIV care and resources for that particular population, because that's a need in this area. But then also look at how do we then leverage the relationships we have with outside organizations that also have expertise. So things like Bangor Public Health and Wabanaki, other organizations that really have that depth of experience meeting the needs of individuals who have HIV and building upon that. So that's another area where there's been a lot of strong collaboration. No one organization can meet all those needs. Our PCHC or Northern Light medical providers, great expertise in the medical treatment of HIV and other infectious diseases, but they don't necessarily have the depth of resources for addressing unmet housing needs or some of the substance use treatment needs. So we want to make sure that we're using the right tools in the right way to meet somebody's needs overall. So that's another area where the flexibility of the CCBHC is going to be really beneficial moving forward in making sure that we're able to meet the needs of the folks that are at highest risk in the community. And I can think of kind of countless examples of situations where those collaborative relationships have been key. Again, we've got our CHCS staff are out there in the community, at the homeless encampments 5 days a week at least, with our partners through PCHC, at times with partners through St. Joe, some through the city public health. Really, again, literally meeting people where they're at, whether it's we've got a large homeless encampment in Bangor right now that's down by the railroad track. So it's meeting people right down there, developing that trust and trying to figure out where those needs are. I may be engaging with somebody I'm trying to, help work with them on, taking that next step around getting housing. But in that moment, they may be feeling miserably sick because of some infection. So that's their priority in the moment. If I'm trying to, push them towards, we really need to work in your housing, their priority in that moment is, I feel sick as a dog, I need to feel better. We want to be able to make sure that we can address that, pivot, and provide that healthcare need that they have in that moment so then they can get to that next step. So we've had opportunities for getting people rapid access to medical care, rapid access to SUD care. If somebody is in that moment, I want to get off, got to give an example, somebody that had been actively using opiates, had been wanting to get off opiates for a while, but it's tough. That transition is not easy. Pulling the trigger, knowing when to make that change is not easy. But the person had a stomach bug, had been really sick for several days and had not been using opiates because of that, and thinking that provides that opportunity. They have the opiates out of their system. If they were wanting to get onto Suboxone, ideal opportunity because they don't have the opiates in their system. They're going to avoid the precipitated withdrawal. So we're able to then, call right up to our partner over at PCHC. Hey, this is a situation. This person's gone X number of days without any use, really wants to get in. Great, we can come right in that afternoon to the walk-in and hopefully get things started on treatment. And those sorts of things don't happen without those relationships already being in place. And I think that's one of the real benefits of the work around not just trying to do everything in-house, but collaborating with partners. It's building those relationships in advance so that when those needs arise, we know who to call. We have those relationships and we can kind of make those links happen to meet people's needs in the moment. So I'm aware I've rambled quite a bit. I'm hoping you may have some questions, Gordon, or thoughts.
Richard, I don't see any questions in the question and answer box. There's some comments in the chat that I will talk about. And I've got some one or more questions, Brian, for you myself. I appreciate your shout out to St. Mary's. I think that since they've adapted their new policies for admission, that you can access their 18 beds without having to go through the emergency department. That Greg Bowers, now that he's in charge of behavioral health there, has been, has been very, very, it's been very helpful. Also in the chat, the acknowledgement of some of our recent work in Aroostook County that I want to comment on, and then I'll ask you a question that not only do we have the new active first mile recovery center in Fort Kent, but we do have a methadone clinic coming to Van Buren. We've got the Recovery High School starting up in Fort Kent in the fall of next year. There's also the new recovery residence in Fort Kent, courtesy of Danielle Farino and the Maine Recovery Council. I know there's 8 beds for men in that beautiful new recovery residence. And now there's a recovery residence in Holton, courtesy of the Attorney General's office and the Maliseet tribe. And I know they're having a open house and celebrating the opening of that facility, I think, Tuesday night next week. And so it's and then in addition, obviously, we have our 3 options liaisons in there, as well as the 2 traditional recovery centers in Holton and Caribou, operated by AMHC. And then we have the treatment facility at AMHC in Presque Isle. So that's just a kind of a broad brush on all the positive things we're doing in Aroostook County. Is it enough? No. We also have the treatment court opening up. That'll be led by Justice Nelson in starting in July. So that will mean we'll have a treatment court available of some type, either a veterans court, family court, or adult treatment and recovery court in all the judicial regions. So we're making progress for sure. But my question, Brian, to you is, I've got in front of me kind of the essential things that a CCBHC has to do in order to get the enhanced reimbursement for Maine Care. I mean, among the most important, I think, are, you have to take everybody, regardless of their source of insurance. You have to, either through partners, and that's really what you've been talking about today, is these collaborations, to have 24/7 crisis care, evidence-based practices, integrated physical and mental health services, among other things. And Mike, those are really all potential game changers in the state. But my question to you is, of those things, which do you think will be most impactful to our statewide efforts to improve our situation?
Yeah, I mean, that's a good question. I mean, I think the low barrier access to care, regardless of payer, and the idea of the rapidity of access to care, that's going to be really important, especially if you're looking at individuals that are, struggling with substance use disorder, in addition to, potential mental health issues. Is that really wanting to capitalize on the opportunity when somebody is at a place where they're ready for change? Because that's again, one of the big things I've seen with options with some of those programs is that being able to meet somebody where they're at in that moment and provide care rapidly. So the idea of, it's like the example of the fellow that we got down to St. Mary's, being able to walk into an office and be seen and to have another, contact with another human being from the field that can help determine what the needs are in that moment. Is this something that is just sort of a routine and we get the person scheduled, they just want to make an appointment? Or is this, we really need to be able to provide, triage and support right now to this individual? And I think that that's one of the benefits of the CCBHC model, is that it requires that and it facilitates that, being able to provide that flexibility in that moment to meet the individual's needs. So I think that is a real game changer, because we want to be able to have rapid access to care and low barrier. that the idea of somebody can just walk in, there's not going to be a wrong door. Somebody's coming into an organization and we'll be able to look at the big picture and assess their needs across the board. And I think beyond that, the enhancement of having the integration of look at their healthcare needs more robustly is important. That's again, that's something that we've developed over the years through the SAMHSA grant and prior programs. Let's look at you can't separate out substance use and mental health conditions. You can't separate somebody's physical health and the mental health. It's all one and the same. I think the separations are things we've created artificially in the past for various reasons, but we really need to look at the whole person. So I think that's one of the game changers is the low barrier access to care. I think while it's having more breadth of services in-house in addition to those partnerships, it's sort of both. We want to be able to know that that we have strong training and providers that can address substance use just as competently as they can address mental health conditions within every organization. That's important. But it also is important to be able to have those partnerships with outside entities as well, and balancing that.
I'm glad you highlighted the collaboration, because I think in the past, in too many instances, the work was very siloed. It really was. I mean, if not flat out competitive.
But that's, I was thinking, I don't know if I included my slides, but the word of competition, we're not trying to compete, and it doesn't, there's plenty of work for everybody. If it's to the point where there's not enough need, that's a great problem to have. Unfortunately, there is so much need. We don't need to be competing, and we don't need to be reinventing the wheel. If there's another organization that's doing something great, we want to emphasize that, build upon that, collaborate, so that then we can focus our energy on the needs that aren't being met and kind of do great work there. Those partnerships are essential. You mentioned the treatment court that's starting up in Aroostook County, which is great. I was talking with the folks down here about that. And that's another, I think of opportunities for CCBHC is we have a treatment court program in Bangor, which is a wonderful program. I do a lot of collaboration with them. But again, the CCBHC, provides, that's another great, partnership there, because, we have a robust, mental health and behavioral health treatment programs here within CHCS, right down the road from the treatment drug court, which is, they have, robust SUD treatment components as part of their team. So having that partnership there when they're identifying somebody who has behavioral health needs that maybe are beyond what that treatment program can in-house provide, we're able to have that seamless partnership and get folks connected with services over here and actively collaborate. So it's an integrated as part of their overall treatment team to help somebody be more successful getting through the treatment court program. And so that's just another kind of exciting opportunity. And it's a great program. It's already sort of an integrated treatment model, but it's how do we then build upon that and partner with them in a way that's going to make that even better.
Well, and I think the CCBHC, and I think I'm right that would you say that there's 5 such programs in Maine now?
I believe so. If Leslie were here, she would be able to tell you definitively. I believe Sweetser, Kennebec, AMHC, us, and I think there is a 5th. I cannot pull out of my brain right now what organization it is, but I believe you're right.
My point was going to be that, we at least begin to see a statewide network of services rather than these siloed programs that don't talk to one another.
Right.
We've struggled mightily on the residential treatment side, that we've got places that have empty beds, and then we have places with a wait list. Right. I do not I'm beginning to understand that, because again, the people on the wait list may need a 3.5 ASAM level of care, and maybe the beds we have available are 3.1. But nonetheless, we now get the residential treatment facilities together once a month to work on these things. We also have the treatment connection, which is getting to the point where you'd want it to be, where people can go online and find the nearest available bed. So all these things have to work together. The options program that you've done such a good job with supervising in Penobscot and Piscataquis County, right? And so it's beginning to be a beautiful thing, but we realize, and the people on this call, has been well over 100 people participating with us today, that it still can be hard to find a particular service. And that's why your example of sending that patient to St. Mary's, I mean, that's just a beautiful thing, because when it works, and what you see that comes out the other end, that's what keeps us all going. So,
Absolutely, yeah.
Thank you.
And there's lots of examples of, like, thinking it's hard getting residential treatment or detox. There's so many moving parts, so many challenges, and part of this, it's gonna take time to kind of build the system out to really meet the needs. But there's an issue of, is the resource not there, or is it just that the person doesn't know how to access the resource? And they're two separate problems. I think we can, if we're able to make sure that, say access to residential care or detox, that if the barrier is figuring out where that is, we can solve that problem through these partnerships, through these relationship building, through connection with other CCBHCs, so that if there's an identified need, we can make sure that there's not a program that has open beds that we're just not reaching out to that solve that. Then you get to a point where that's not the issue. There just is a lack of sufficient resources. Then that allows us to have that data and provide that feedback, so we as a system can look at, okay, this is not a matter of underutilized resources. This is a matter of the need is greater than the resources out there. How do we then develop the programs to meet that need?
And we realized, before people start putting comments in the chat about it, that, while we've made some investments in facilities and beds, we have a workforce crisis in behavioral health. We have at least one of our major detox facilities closed this past week, 2 weeks actually, because of strictly because of workforce issues. And it's heartbreaking. I mean, we've got everything in place, but it's not just the bricks and mortar. You have to have people that can work there. And that's not an easy that's not a easy problem to fix in the short term. You have to have a number of strategies, and we have a lot of great people across the state working on those strategies, whether it's in the community college system or elsewhere. I also wanted to comment, Brian, on the fact that the CCBHC model will become even more important in 2026 if we start losing main care patients to losing them from the main care program because of the changes in federal eligibility. We know that's coming, and this it is a safety net program that and so this will only become more important as we face those challenges going forward. Richard, you've been monitoring the questions. I can answer this question from
I don't think there
the chat.
still aren't any questions.
Are there any other questions other than that one that just came in? Wellsprings facility at the New Horizons in Hamden has been closed because of workforce issues for a few days. I believe they're reopening on Monday. And this is I'm not telling tales out of school. I mean, people need to know these things. And that's why we do the daily bed report, to enhance the treatment connection operation. And this has been, I believe, the third time that the facilities had to be unavailable to us for stretches of time. We're very fortunate that Wabanaki very frequently has beds at their detox facility in Bangor. We have the beds at Milestone. We have beds now at Liberty Bay and at Pine Tree and at St. Mary's. So, on any given night, we see the bed list every day. There's usually a bed available, but not always. And again, if our go-to kind of gold standard programs have been at Milestone and Wellspring for a number of years. So when one of those facilities is shut down, it really does put a lot of pressure on the system. So we got to work on workforce, and again, we realize it is a temporary closure. I don't want to make more of this than is needed, but I do think it's something that we have to acknowledge as we try to build out a statewide network of continuing of care from the time that the person decides that they're going to try to get help tonight to them in a solid certified. I think we got 110 certified recovery residences out there, and everything that in between that, and then following people in recovery through the process of recovery coaches, recovery centers, recovery friendly workplaces. It's a good chance to promote that. We just had, the state just signed on to be a recovery friendly workplace. It's one of the first state organizations as a state, 12,000 employees in state government who will now be trained in our modules, and it's just it probably doubles the number of employees, because we had 83 employers already certified as recovery friendly workplaces. So again, it's all a package and a network, and we're really excited. Can anyone be on the email list of beds available? Yes. Communicate with Karina O'Leary, karina.o'leary@maine.gov, and she will send the daily bed report to anyone. I'm sure there's people from OBH on this webinar that can make that address available. Throw it up in the chat. Richard, you could do that to make sure that people have Karina's address. She's done a beautiful job with that, by the way. It's not easy every day, and Richard has substituted from time to time when Karina or Stacy's unavailable. But I pay a lot of attention to that bed report. We're also very proud of the fact that Liberty Bay and Pine Tree have beds, are now enrolled in Maine Care for their beds, so that we can say that, to my knowledge, there isn't any facility in Maine providing medically supervised withdrawal services that is not available to Maine Care patients. So that couldn't, we don't have a, private pay over here, Maine Care here, uninsured over there. All our beds are available to everyone, and we try to make good on that promise every day.
Jennifer has another question about Wellspring. I'm not sure if.
Can you read it to me? Can you see it there, Richard?
Sure. Is there feedback coming from providers like Wellspring regarding what assistance may be helpful in solving the workforce shortage issue? Is the Maine Care reimbursement rate such that the wages are competitive enough to attract talent?
Well, that's a complicated answer. Brian can weigh in as well. Maine Care reimbursement will never be generous. It will never be. It's difficult for Maine Care to keep its rates up to date with respect to cost. So even if they do a major, and they do these studies all the time, and they increase rates all the time. Well, now we have a cost of living increase, which is somewhat helpful. But again, we're not in a position really to know what is going to be a going rate for an RN for overnight services in rural Maine. And you're also competing with hospitals and a lot of other demand. So the shortage of workers, no, I don't think you'll find anybody in state government that's saying that the Maine Care rate is sufficient to attract, to be attractive. The best we can do is try to cover as much of the cost as we possibly can, and then have also some uninsured contracts that will pick up and pay for people who are uninsured. So it's going to be it's an enormous challenge, and we just have to keep at it all the time. Yeah, thank you for putting Karina O'Leary's email address in there.
I actually put mine. I'll pass it on to Karina.
There is another question here. This would be the last one because it's 12:30. Will there be a discussion on prevention, school programs that let youth know the impact of their future with drug use, catching the folks who are selling drugs and enticing youth to youth? Well, our webinar in February gets at that. The Icelandic model gets into that quite a bit. And yes, there's all kinds of activities in our Maine prevention network trying to get a commitment to have a evidence-based prevention program in every school and in every community by the end of 2026. The Recovery Council, a lot of settlement dollars are being devoted to that. And you've got, remember, settlement dollars in 39 different communities and counties as well. And I find that a lot of that work, they want to support, they want that money to stay local. So if you're in a community that's got 10,000 people in it, it's getting money every year for 18 years, it's maybe only $100,000 a year. It's not millions, but that's $100,000 that could be put into a source of strength program in the school or something. So we really do try to cover all the pillars with somewhat equal attention. Harm reduction. We're not going to back off our harm reduction activities, regardless of what the federal government tells us. Recovery support, treatment, and prevention. You wish you could put all your money into primary prevention because we absolutely need to have fewer people start. But, to end this on a positive note, as well as thanking Brian and CHCS for everything that they're doing in this program this morning, I will note that we haven't lost a person under age 25 to a fatal overdose this year since February. It's one of the reasons that our average age of an overdose person, of a decedent, has increased from age 41 when I started this work with Governor Mills in 2019 to age 47 today. Now, that's not because more older people are dying of a fatal overdose. It's simply that we're losing fewer young people and we're all aging. And so that's the phenomenon. But when I saw that, that's quite a large increase in just 7 years. But I point that out because, and if you look at the latest MIAS data too, the survey that was just released from that we do tens of thousands of middle school and high school students, there are fewer kids using, it says, if you believe what the kids tell us, there are fewer kids using drugs, fewer kids using alcohol. We are making progress. Brian, thank you so much. Thank you to Lorena and Adapt, as always, and Richard, my partner in crime. Have a great weekend, everyone, and we'll see you hopefully with our friend Roland in January again. It's going to be on January 9th, not January 2nd. Thanks a lot. Have a great weekend.
Thank you, Gordon.